orthopedic emergencies in lower limb. Dr. Haytham, you can listen me, sir.
Yeah, good.
So our topic is about orthopedic emergencies in lower limb and how we will deal with them in our ER. So our main objectives to identify the emergencies in lower limb, clinically recognize them, and identify the. Hello?
Yes, we are with you.
Okay. So we have to identify clearly the limb emergencies and properly diagnose them, and to do their initial assessment and do their management. As our ER physician, we have to do all this one. So very important to early diagnose these emergencies, and because if we diagnose it on the time, it will impact on the patient function and the survival of the limb. So what type of the orthopedic emergencies we have in lower limb? So most commonly are fractures, dislocations, crush injuries, compartment syndromes, vascular injuries, and wounds and infections. So as ER physician, what we should do, Yani? So our initial approach to the patient should be ABCD, yani airway, breathing, circulation. Okay, we should follow with the vital signs of the patient. We should take history from the patient, proper history to understand the mechanism of the injury, to ask the patient at what time happened the injury, fall down or road traffic accident. Okay. The main important thing in the assessment is the neurovascular examination. In all patients with orthopedic and limb injuries, we should do neurovascular examination. For this one, we should expose the patient. We should properly expose the patient and examine the limb properly at the site of the injury and the distal to the site of the injury. The other thing, we should do the proper imaging to properly diagnose. We should ask at least two views of the images, AP and lateral. In limbs, mostly we need AP and mostly we need to do views, AP and lateral views. So before discussing the fractures or other abnormalities, we should understand there are some red flags. Yani the things for, if we found these findings in the patient, we should call the orthopedic specialist immediately, or we should call our team leaders immediately. If the patient has severe pain, or there is absent pulses, if there are open fractures, or if there is any neurological or vascular deficit, if there are open fractures, if there are signs of infections, if any of these signs are present in the patient, we should immediately involve the orthopedic specialist on call, or we should involve our team leaders. So we will discuss the lower limb injuries according to the location and by parts. So first of all, we will discuss about the pelvis. So as we know, the anatomy of the pelvis is formed by the combination of different bones like ilium, ischium, pubic bone, and the sacrum bone. So in the second picture, we can see the radiological anatomy of the pelvis. So all the pelvic bones are bind together with the strong ligaments. As generally in the whole body, all the bones are joined together with the help of the ligaments, and muscles are attached to the bone with the help of the tendon. So bones are held together with each other with the help of the ligaments, and muscles are attached to the bone with the help of the tendons. So pelvic is a very important part which containing different organs also inside it, like urinary bladder, some ends of the intestine, rectum, reproductive organs, female reproductive organs. So any injuries to the pelvic can give injury to the organs of the pelvis. So now we can see some important structures passing through the pelvic, because any fracture in the pelvis can give to the injury to the vascular or to the nerves passing through these one. So abdominal aorta at the level of the sacrum divides into two branches, mainly into common iliac artery, right and left, which further divides into the internal iliac artery and external iliac artery. Internal iliac artery profusely provide blood to the pelvic organ, and the external iliac artery continues into the femoral artery. In the same way, there is a venous system going from down to the upward in the same way. So now we will see the pelvic fractures. Any breakdown in the bone of the fracture disturb the pelvic ring. So any fracture in the ilium bone, ischium bone, or pubic bone can disturb the pelvic ring. So these fractures associated from the minor fall to the high velocity trauma. So high velocity trauma can cause displaced fractures, and they can injure to the blood vessels or the organ located in the pelvis. So pelvic fractures can be classified in the stable fractures and unstable fractures. So stable fractures are usually due to the minor fall down or due to some sport injuries. Okay, it involves maybe the pubic ramus or maybe the avulsion fractures of the wing of the iliac bone. So avulsion fractures may be due to the rupture of the ligaments also. These can be a minor fractures, and patient can be hemodynamically stable in these conditions. So avulsion fractures can be of the iliac crest, anterior superior iliac spine, anterior inferior iliac spine, pubic symphysis, and ischial tuberosity. We can see all these one in the picture also shown. So these pictures are also shown the stable fractures of the pelvis, which involve the wing of the ischium bone, can involve the pubic ramus, can involve the superior pubic ramus, inferior pubic ramus, or ischial tuberosity. So all these fractures will be stable, and patient will be stable, and there is no chance of injury to the blood vessels and to the nerves. So hemodynamically, these patients will be stable. So unstable fractures are those fractures which are break the pelvic ring in the multiple fragments. These fractures are due to the high energy trauma, like fall down from the height or from RTA, like motor vehicle accident. So unstable fractures, they are at a high risk for the injury to the pelvic organ and to the blood vessels and to the nerve. So any unstable fracture can lead to the massive bleeding in the pelvis, and patient can be hemodynamically unstable. So we should monitor the vitals of the patient continuously. If there is any tachycardia, if there is any decrease in the blood pressure, so it means there is any injury to the blood vessels. So what type of the blood vessels? This may be the main blood vessels like iliac arteries, or maybe the injury to the blood pelvic organ, which can further bleed. So we can classify the fractures of the pelvis by the name known as Young-Burgess classification. This classification depends upon the direction of the force. For example, anterior posterior compression. if the force is from the front, so it will hit from the front side of the pelvis, and it will can break the symphysis pubic. And anterior posterior compression can further divide into 3 classification, depends upon the disruption. So we can see in the picture lateral compression, anterior posterior compression, and vertical compression. In the lateral compression, when the force is hitting from the lateral side of the patient, it can be divided into 3 parts. When the first part only there is fracture, but the symphysis pubic is intact. In the second type, there is a fracture of the pubic ramus and the interior part of the sacral. In the third type, when force is coming from the both sides. Anterior posterior compression, when there is rupture of the pubic ramus, we know the pubic ramus is firmly attached by the help of the ligaments. It has two parts of the ligament, anterior and posterior. They are very strong ligaments. So these fractures are mostly due to the high velocity traumas. So in anterior posterior compression, if there is complete rupture of the symphysis pubis, so it will lead to the open book fracture of the pelvis. And this is the high risk of the fracture, which can lead to the injuries to the pelvic organ and to the blood vessels and to the nerves. And the third type is the vertical shear. This type of classification, when there is a fall down from the height on the one leg, yani then when the force is moving vertically from downward to the upward and divides the one half of the pelvis superiorly to the other half. The other type, fourth type, is the complex type, when the different forces act on the pelvis and give different types of the fracture of the pelvis. So these are some pictures, radiographical pictures, CT scan, showing the open book fracture of the pelvis when symphysis pubic is completely ruptured. The other picture also showing the same, involving the fracture of the both ramus of the pubis bone and the anterior segment of the sacral part. In this picture, we also see the same open book pelvis fracture. So clinically, there will be the ecchymosis, bruises. Patient will feel the severe pain in the area of the trauma. Patient was unable to stand or walk. If there is any associated injuries to the organs, so maybe there is a urethral injury, rupture of the bladder, rectal injury, vaginal injury, or even can lead to the injury to the abdominal organs. So if there is, for example, injury to the urethra, there can be a hematuria also. So we can clearly ask the patient about this one, about urine, color of urine. So as ER physician, what should we do, Yan? We should assess the patient fully as ATLS approach. We should examine the patient by exposing the patient. We should take history. We should check the vital signs. So if there is any tachycardia, there is any decrease in the blood pressure, so we should suspect is there any injury to the blood vessels. So to identify the X-ray, to identify the fractures, we should do the pelvic X-rays. We can do AP and lateral view. So to identify any unstable fractures, we can do CT scan. To rule out any injury to the internal organs of the pelvis, we should do fast ultrasound scan. So if any injury to the internal organs, we should call the GS consultation immediately, orthopedic consultation immediately, because any delay can lead to any severe hemorrhage, and this can maybe lead to the lethal condition of the patient. So if patient have stable fractures in the ER, so these patients may be hemodynamically stable. They just need only analgesia. So we can advise the patient to be mobilized as they tolerate the pain. And these patients can be discharged from the ER if they are stable. And after proper imaging, with advice, yani they should not do aggressive exercise or should not do the aggressive sports. So these patients can be discharged from the ER. But if the patient they have unstable fractures, these patients need observation, so need proper analgesia. From our ER side, what we should do, yani, we should apply pelvic binder. First of all, we should apply pelvic binder, as we can see in the picture, pelvic binder. If pelvic binder is not available in the ER, so we can take one bed sheet and pass through the back of the patient and just tie it on the upper side at the level of the symphysis pubis. So this pelvic binder is very important because it can stabilize the fragments of the fracture part of the pelvic ring and can support and can avoid from the injury to the internal organs. And pelvic binder can itself stop the bleeding. So unstable fractures, they need mostly fixation. These fixations can be open reduction and internal fixation. So as we can see, these are the pictures are the example of the open reduction and internal fixation. The second picture is the example of open book fracture and open reduction and internal fixation. So these are the pictures of the external fixation of the pelvis fractures. This is also open reduction and internal fixation. So now we will discuss hip dislocations. So hip dislocation is happen when there is hip joint is a kind of ball and socket joint formed by the combination of the head of the femur and the acetabulum cavity. Acetabulum cavity is formed by the combination of the pelvic bones, ischium, pubis, and pubic bone. All these three bones form the acetabulum cavity, and the head of the femur is attached in this cavity, which is a kind of ball and socket joint. This ball and socket joint, if displaced, so there will be a hip dislocation. Hip dislocation can be classified according to the position of the head of the femur. So this can be a posterior dislocation, can be anterior dislocation, or can be a central dislocation. So out of these, posterior dislocation is most common type of the dislocation. It usually occurs when there is a direction of the force from the anterior to the posterior side, like dashboard injury. So in the picture, we can see the position of the limb during the hip dislocation. So if there is posterior dislocation, so limb is slightly flexed at the level of the hip, abducted, yani internally rotated. Leg is shortened. So when there is anterior hip dislocation, it will be the opposite. Leg will be the externally rotated, abducted, and slightly flexed. So this is opposite to the posterior dislocation. So as we know, the important anatomical structures passing through the pelvis, like sciatic nerve and the femoral artery. So these dislocations can injure to the sciatic nerve and the femoral arteries. And so if there is any sign and symptoms of the neurovascular injury, so we should immediately call the orthopedic specialist, because these need fixation to reduce and fix this neurovascular injury. So if there is any neurovascular injury like sciatic nerve injury, so there will be the signs of paresthesia on the foot, because sciatic nerve is a sensory and motor nerve. It supplies to the sensory, to the dorsal and the ventral part of the foot, and there will be a sign of the foot drop. So patient cannot raise his foot. So if there is injury to the sciatic nerve. So central dislocation mostly due to the fracture of the acetabulum cavity, and when the head of the femur is moving inside the pelvis. So clinically, there will be the severe pain, and patient will be unable to the walk or bear the weight. And we can see the deformity of the limb. So most important to assess the neurovascular injury in these dislocations. The most important is the sciatic nerve injury. When there is sciatic nerve injury, there will be the foot drop, and patient cannot raise his foot. If there will be injury to the femoral nerve, patient can maybe feel paresthesia to the interior thigh. He can feel tingling sensation. He can feel a slip of the limb. So diagnosis of the dislocation can be clinically or can be by the imaging. Clinically, we can see the deformity, clear deformity, because joint head of the femur will be out of the socket. So we should do the X-ray, AP view, and the lateral view. So if there is any suspicion of the fractures, so we should do the CT scan, because if there is any segment of the fracture trapped inside the joint cavity, and we cannot do the reduction, because hip dislocation or any dislocation is an orthopedic emergency. We should reduce these dislocations within 4 to 6 hours, because if these dislocations will not be resolved, it can be lead to the severe complications like limb ischemia if there is any vascular injury, or can be the neurological injury, and can lead to the disability of the patient. So these all dislocations need urgent reduction within 4 to 6 hours. So can do be the closed reduction or open reduction. So there are different types of reduction. If there is any posterior hip dislocation, so there are different techniques. So they are known as Captain Morgan technique, Whistler technique, Alice maneuver technique. If there is anterior hip dislocation, this will be the Stimson maneuver, and the traction and the counter traction. So these techniques are the complex techniques, need experience. So mostly these techniques are performed by the orthopedic specialists. So as ear physicians, our duty to early diagnose these dislocations and immediately involve the orthopedic specialist to decrease the risk of complication. Because if these will not be reduced, like if there is an injury to the vascular injury to the femoral artery, it can lead to the avascular necrosis of the head, because head of the femur is poorly perfused, and if there will be injury to the artery, it can lead to the avascular necrosis of the head of the femur. So these dislocations should be immediately dealt. So for the dislocations, we should do the pre-X-ray and post-reduction X-ray. So any dislocation should be done pre and post X-ray, and it should be documented in the system after reduction. So this will be the documentary evidence that reduction has been done. So if open reduction fails, we should process to the if closed reduction fails, we should process to the open reduction. Now we will discuss for the femur. So this is the anatomy of the femur. We know the femur is divided into the head, neck, shaft, and distal part of the femur, having lateral epicondyle, medial epicondyle. So the fracture of the femurs. So this is also the anatomy of the femur. We can see clearly the head, neck, trochanteric, intertrochanteric, lesser trochanteric, because these are the parts where fractures can be happened. In the other picture, we can see the anatomical structures passing through the neck of the femur. If any fractures in this area can also injure to the vessels and the nerves passing through the femur. So we can classify the fractures of femur according to their location, according to their displacement. So fractures of proximal femur can be divided into the fracture neck of the femur. So we can divide the fracture of the proximal femur into the neck of the femur, intertrochanteric femur, and subtrochanteric femur fractures. So fracture neck of the femur can be divided into the subcapital if it is under the head of the femur, mid cervical, and basic cervical. So we can classify the fracture head of the femur according to their displacement also. So in this picture, we can see different types of the fracture of the neck of the femur. So if there is incomplete fracture, this will be the type 1. Type 2 fracture will be the complete fracture of the neck of the femur, but will be undisplaced. Type 3 will be the complete fracture, but it will be partially displaced. Type 4, it will be the complete displaced fracture. So this is 4 types of the fracture neck of the femur. We can also describe these fractures as intracapsular, because the fracture neck of the femur, it will be inside the capsule of the joint, and can be extracapsular fractures like intertrochanteric fracture and subtrochanteric fracture. Subtrochanteric fractures, this is the area below the intertrochanteric up to the 5 centimeter. After 5 centimeter fracture, it will be count as the fracture shaft of the femur. So there will be some other fractures of the greater trochanteric and lesser trochanteric fractures also. So we can classify the fractures of the femur neck, proximal part of the femur also depending upon their angle of displacement. If angle of displacement is less than 30 degree, so these will be the stable fractures. If angle of the degree between 30 to 50 degree, this will be the unstable. If angle is more than 50 degree, so these will be the highly unstable fractures. So we can see the type 1 fracture. This is a linear fracture. So these fractures can be missed in the ER or can be missed from the X-ray. because these fractures may be impacted fractures. The part of the fracture is impacted in other part of the bone and cannot be seen on clearly on the X-ray. So these fractures can be missed from the ER. So we should clearly see the X-ray. If there is any doubt, we should do another view. And if there is another still doubt, we should do CT scan. So the other type of the fracture shaft of the femurs. Fracture shaft of the femurs due to the high velocity trauma like RTA. As fracture proximal femur can be in old age or can be in young age. Old age due to the osteoporosis, and in young age due to the high velocity trauma. Fracture shaft of the femurs mostly in young patients because of the high velocity trauma like RTA or sport injuries or fall down from the height. So there is a high risk of injuries to the blood vessels, and there is a high risk of blood loss, and this blood loss can be 1 liter or 1.5 liter, or if there is open fracture, this loss of blood can lead up to the 2 liter and more than 2 liter. So fracture shaft of the femurs can be divided into the transverse fracture, linear fracture, oblique fracture, spiral fracture, and comminuted fractures, and compound fracture or open fractures. So there is some radiological pictures showing the fracture shaft of the femur. So the first picture showing the displaced fracture shaft of the femur. These are the complex comminuted fractures. So this is the spiral. This is a spiral type of the fracture when there is a rotationary force. So we should be very careful for the spiral type of the fractures, especially in the pediatric cases, because this may be the assault or the child abuse. So any doubt for this one, we should do documentation in the system if there is any spiral type of fracture because of the risk of assault, or if need, we should involve the administration, we should inform DOD. So if there is maybe a child abuse. So these are also pictures showing displaced fractures of the shaft of the femur. And this is the internal fixation. So third type is the distal femur fractures. So we'll see the anatomy of the distal femur. It is the surface which is making the joint with the knee. So it has lateral epicondyle, medial epicondyle, lateral condyle, and medial condyle. So the important structures passing through the distal femur or back of the knee. This is the popliteal artery or vein, common peroneal nerve, and tibial nerve. Popliteal artery, this is a continuation of the femoral artery, and the common peroneal nerve and the tibial nerves, they are the branches of the sciatic nerve. So any injury in the distal femur will be on the high risk for the neurovascular injury of these vessels and the nerves. So mostly fractures of distal femur due to the high velocity trauma in the young patients. And in elderly patients, this happens because of the osteoporosis. Even due to the minor trauma can lead to the fracture of the distal femur. So fracture of the distal femur can extend to the joints and can disturb the movements of the joints. So we can define the fractures of the distal femur into as extra-articular fracture, which are not involving the joint. Type 2, partial articular fractures, which in which the one part of the condyle involving the joint, and the type C, when there is complete involvement of the articular surface. So in distal femur, there is also very important, especially in the pediatric cases. We can divide the fractures into the different types depending upon their types. So these, because in the distal femur there is a growth plate which lead to the growth of the femur bone. If there is fracture in the distal part, it can disturb the growth of the femur. So we can divide these fractures also according to the Salter-Harris classification. So there are 5 types of Salter-Harris type of classification which disturb the growth plate. Actually, growth plate, this is known as physis. Physis, this is a transitional area from the metaphysis to the epiphysis. Epiphysis, this is the most distal part of the bone, which makes the surface with the joint, and the metaphysis is above the physis. And this physis is the transitional part of the, this is a transitional space between the epiphysis and the metaphysis. So any fracture on this area can disturb the growth of the femur, and this can lead to the growth discrepancies, and there will be the difference in the length of the limb. So we can define these according to the Salter-Harris classification in 5 types. Type 1, this is the transverse fracture of the physis. So this is the fracture which is very difficult to identify on the X-ray. So like all other fractures, we should do AP and lateral view of the limb to identify these fractures. So type 1 is the most type which can be missed in ER, because in X-ray we cannot see any clear line of the fracture, because this is like slip of the physis. The second type, which is the most common type of the classification of the Salter-Harris type, in which fracture passes through the transversely through the physis and going upward to the metaphysis and making fragment of the triangular type of the fragment of the fracture. So this is the most common type of the Salter-Harris type fracture in the distal tibia. The third type is the type when a fracture line passes through the physis and epiphysis and involves the joint surface. Fourth type, when the fracture line passes through the metaphysis, physis, and epiphysis. The fifth type, when there is crush of the physis, when the patient falls down from the height. So these classification is very important clinically, because we should classify the fracture according to this one, and this defines the treatment of the patient also. Because type 1 maybe no need any intervention, we can manage this one conservatively by applying the posterior slab or cast. Sometimes we cannot identify this one on the X-ray, but clinically we see there is bruises, ecchymosis, and there is swelling and tenderness. Patient cannot bear the weight, cannot walk. So even we cannot see the fracture, we can apply the safety slab for this patient. And the other types, type 2 and type 3, also can be managed conservatively if the displacement reduce successfully, and can apply a cast and can be managed conservatively. If not reduced properly, should be open reduction and internal fixation. Because if these will not be reduced or their anatomically alignment will not be done, it can be lead to the growth arrest and then it will lead to the discrepancies in the length of the limb, and it can lead to the invalidity of the patient. So this classification is very important, and this defines the treatment of the patient. So these are some pictures showing the fractures of the distal tibia, distal femur, or supracondylar fractures. This also type of the supracondylar fractures with some open reduction and internal fixation. We can also classify the distal femur fractures according to their location and the type of the involvement of the distal parts. Type 1, when there is oblique fracture but not displaced. Type 2, when there is oblique fracture but partially displaced. And the type 2B, when this is the comminuted. This one displaced and comminuted. Type 3, this depending upon the involvement of the epicondyles. Type 3A, when there is lateral involvement of the condyle, epicondyle. Type 3B, when there is the medial involvement of the epicondyle, and type 3C, when there is involvement of the both epicondyle. Type 4, when there is involvement of the condyles, but they are involving the joint surface also. So as we see, the fracture of the femur, of the proximal part of the shaft of the femur and the distal femur. So all these fractures, clinically patient will present with the severe pain, tenderness, unable to bear the weight, unable to walk. Clinically, there will be the ecchymosis, bruises. Okay. So any injury to these limb, or we are suspecting there is fracture femur, we should fully expose to the patient. We should see clinically if there is any ecchymosis, we should suspect there is fracture. We should do the proper imaging. We should always ask for the 2 views of the X-ray, AP and lateral view. Sometimes views are not good, so we should not leave this one. If there is views are not good, we should do proper views. Sometimes X-ray technicians, they are not doing proper views, so we should ask for the proper views, because this is very important to identify the extent of the fracture and the displacement of the fracture, and all this one lead to the proper management of the fractures. So clinically, patient will present with the pain, unable to bear weight and walk. So we should examine for the ecchymosis, and clinically signs and symptoms. Clinically, this fracture of the femur, neck of the femur, or shaft of the femur and distal of the femur. So this limb will be the externally rotated and will be the shortened in the length as compared to the other limbs. So we should notice all these clinical signs, and we should suspect the fractures. So as ear physician, how we should manage these patients? We should provide proper analgesia to the patient to reduce the pain. We should assess for the neurovascular injuries. If there is any neurovascular injuries, we should properly involve the team leader. We should involve the orthopedic specialist as soon as possible, because any delay can lead to the complications of the patient. So if fracture of the proximal part of the femur, it can be give to the injury to the sciatic nerve, femoral artery, okay, and the femoral nerve. So how we will assess this one? So there will be the foot drop. So we can ask the patient to raise the foot. Patient will be unable to raise his foot. So because sciatic nerve is a sensory and motor nerve, it supplies to the sensory and motor innervation to the ankle and the foot. So patient will be unable to the dorsiflex and dorsi extension of the foot. So sensory loss, we should check for the sensory loss also. Yani if there will be injury to the femoral nerve, so patient can feel the tingling sensation in the interior part of the thigh. Patient can feel the severe tightness of the thigh part. If there is any tightness, we should suspect for the compartment syndrome. This is also an emergency. We should not delay this one, and we should involve the orthopedic specialist as soon as possible. So after providing proper analgesia to the patient, we should immobilize the limb. How we can immobilize the limb? We should apply skin traction. Skin traction is available in ER. So we can see in the picture skin traction. This one has the blind end and the open ends. Blind end we can fix with the foot, okay, and the open ends we can roll on the lateral aspects of the limb, and we can roll it with the crepe bandage. So in this way we will immobilize the lower limb, and we should hang the weight with this one. How we can calculate the weight? How much weight we will hang? So there is a formula, simple formula, which tells us about 10% of the body weight. So if patient is about 60%, 60 kg, so this needs 6% of the body weight, yani 6 kg weight. So if there is pediatric cases, so we can fix it with the posterior slabs, or need we can apply the cast to immobilize. So if there will be the undisplaced fractures, so patient may be discharged in pediatric cases, but most of these cases they need surgical intervention. So they need open reduction and internal fixation. So as ER, we should manage the pain, we should immobilize the limb, and involve the orthopedic specialist for further management. So next we will discuss the fractures of the patella. So patella is this small bone known as also a kneecap, which covering our knee joint, attached to the tibia, fibula, and to the femur with the help of the ligaments. So fracture of the patella also can be due to the fall down or high velocity trauma. These fractures can also be classified according to their displacement, according to their location. So these can be undisplaced, displaced fractures, community displaced, transverse, or avulsion fractures due to the rupture of the ligament. So as we see before also, behind the knee there are some important arteries and nerves passing through. This is the popliteal artery and the peroneal nerve. Popliteal artery, this is the continuation of the femoral artery, yani which at the level of the distal femur, it will be continued as the popliteal artery. The peroneal nerve, this is a branch of the sciatic nerve. Sciatic nerve at the level of the distal femur divides into the common peroneal nerve and the tibial nerve. So any injury to the distal femur or to the knee can lead to the injuries of these anatomical structures, which can be dangerous for the patient. So any injury can be dangerous for the patient. So these are the pictures showing fractures of the patella. So if these are displaced fractures, they need open reduction and internal fixation. We can see the tension wire fixation and K wire fixation. So knee dislocation. Knee joint is a very strong joint, and this will be dislocated due to the high velocity traumas, or maybe after fall down. So for the diagnosis, it will be clearly visible. There is a deformity of the knee joint, and patient will be unable to stand or walk, cannot bear the weight. And we should do the radiological imaging. We should ask X-ray, AP, and lateral view. So if there is any doubt for the fracture, involvement of the fracture, we should do CT scan also. So any dislocation, this is an emergency, because this need to reduction as soon as possible, because if we will not reduce this one, it will be continuous injury to the neurovascular bundle, and it can lead to the severe complications of the limb. So we can divide knee dislocation according to the location: anteriorly, posteriorly, laterally, and medially. This classification is known as Kennedy classification. So this according to the displacement of the tibia. There is another classification. This is Shenek classification. This classification depends upon the involvement of the ligaments of the knee. As we know, knee has anterior cruciate ligament, posterior cruciate ligament, lateral cruciate ligament. So if any involvement, this classifies according to the Shenek classification. Type 1 is involves one type of the ligament injury. Type 2 involves 2 ligaments. Type 3, 3 ligaments. And type 4 involves 4 ligaments. And type 5, if there is multi-ligaments involvement. So here we can see this clinically, there will be the clear deformity, and patient will present with the severe pain. There may be ecchymosis. There may be swelling. So if any dislocation, we should trial for the closed reduction. If closed reduction fails, so this can lead for the open reduction and maybe fixation. So for us as ER physician, we should identify this one, and this one easy to identify as there is clear deformity. Patient cannot stand, cannot walk. We should give proper analgesia to the patient. We should check for the vital signs. We should check for the neurovascular injury, because any dislocation can lead to the neurovascular injury. So if there is injury to the tibial nerve, so patient will be feel loss of sensation on the plantar aspect of the foot. If there is injury to the peroneal nerve, so patient will be cannot feel the sensation on the dorsal side of the foot. If there is and these nerves provide motor innervation also, and patient will not do the dorsiflexion of the foot, and there is a foot drop. So all these dislocations should be diagnosed immediately and managed immediately, because any delay can lead to the complications. So for the imaging, all dislocations should be do the pre and post reduction imaging. This is very important, and we should document this one as the reduction was successful. If close reduction not successful, so it will lead to the open reduction. Now we will see the fracture of the tibia. So there is tibial plateau. Tibial plateau, this is the most proximal part of the tibia, which makes the joint surface with the knee joint. So any fracture of this part, this will affect to the joint, knee joint. And this always due to the high energy trauma in young patients, or due to the fall down from the height, or maybe due to some sport injuries, or in old age due to the weak bones or like osteoporosis, and can be a low energy trauma in old age, can also lead to the fracture of the tibial plateau. Tibial plateau is very important because it's bearing about maximum weight of our body, about 40% laterally and 60% medially. So fractures of the tibial plateau, most of the fractures of the lateral side of the lateral tibial plateau. So clinically, the same signs and symptoms as in other fractures: severe pain, swelling, tenderness around the knee, difficulty or inability to walk or bear the weight, limitation of the knee movement. We can see the bruises. So all this one, we should expose the limb properly and properly examine for all these signs and symptoms. This is very important. So for diagnosis of the tibial plateau, we should do the X-rays. Again, AP and lateral view. If there is any involvement from the joint, so we should do the CT scan to the proper assessment of the fracture. Sometimes there is the fragment of the fracture inside the joint, so we should do CT scan also. So for the management, if the fracture is not displaced, we can apply the cast or we can apply the posterior slab, and patient can be managed conservatively. If the fractures are displaced, so this need maybe close reduction and cast and the follow-up. So if there is complex fractures or there is involvement of the joint surfaces, so this may be need open reduction and internal fixation. And the recovery of these fractures, it will take long time, maybe 3 to 4 months. And the proper healing maybe take up to the 1 years. So this is the X-ray. Here we can see the linear fracture of the tibial plateau. This is a non-displaced fracture. So this type of the fracture also difficult to identify on the X-ray, and you can make missed in ER. So not to be missed these type of the fracture, so we should clinically examine. If we see there is any bruises, ecchymosis, clinically there is swelling, and patient is unable to bear the weight, and the movements of the joint is restricted, so we should do CT scan also, not to miss this type of the fractures. So this is another picture showing the fracture of the lateral tibial plateau. The second picture showing the fracture of the tibial plateau extending up to the joint surfaces. So there's also type of the tibial plateau fractures, radiographical images. This is the CT scan showing the fractures of the tibial plateau. So this is the anatomy of the tibia and fibula. As we see the most proximal part, this is the tibial plateau, the shaft of the tibia, and the distal part of the tibia, which has the lateral malleolus and medial malleolus. So in fracture of tibia and fibula, some there are red flags. We should take care of these things because these fractures are mostly because of the high velocity trauma, like RTA, or fall down from the height. So these patients maybe have open fracture or maybe closed fracture, and there is most of the risk for the neurovascular injuries, compartment syndrome. So as for ER physician, we should properly assess the patient. We should expose the patient. We should assess for the clinically to see the ecchymosis, bruises, swelling. We should palpate. We should see the tenderness. If there is any tightness, we should suspect compartment syndrome. So patient can present same as other fractures with severe pain, inability to bear weight or stand or walk. We can see the deformity. If there is open fracture, we can see the bone outside of the wound. So fractures can also be classified as open fracture or closed fracture. Closed fracture when skin is intact, open fractures when skin is not intact. So for all these patients also need proper imaging, need x-rays, AP and lateral view. So if there is comminuted fractures, open fracture, we should do the CT scan for the proper assessment of the fracture, and we should assess for the neurovascular assessment also, because displaced fractures, as we discussed, can lead to the injury to the tibial artery, tibial nerve, and the peroneal nerve. So these are the pictures showing the fracture of the tibia. These are the comminuted fractures, and we can see the swelling. There is bruises, ecchymosis. So we should assess this one for the compartment syndrome. If there is any tense, patient can say if there is severe pain and pain is diffuse, increasing in the intensity. If there is any these of the signs, we should suspect compartment syndrome. These are also the pictures showing the fracture of the shaft of the tibia. So this is also the picture showing the fracture shaft of the tibia and fibula. Sometimes for the fracture shaft of the tibia and fibula, we have to do x-ray for the ankle and x-ray for the knee joint, because sometimes fracture in the mid shaft of the tibia but can give fracture to the proximal or distal part of the fibula. So for any fracture of the shaft of the tibia, we should do x-ray for the knee joint and for the ankle joint. So these are some pictures showing the internal fixation of the fracture shaft of the femur. Fixation can be done by the plating, by screws, or by the IM nailing intramedullary nails. These are the fixation by the plating or by external fixators. So for our side, ER physician, we should properly assess the case. If there is any comminuted fracture, open fracture, we should involve the orthopedic specialist immediately, because there is risk of complication like compartment syndrome, neurovascular injury, and we should monitor the patient for their vital signs. If there is any tachycardia, any decrease in blood pressure or fall of blood pressure, so we should suspect vascular injury. So for any type of the fracture, we should immobilize the limb. We can immobilize by applying the posterior slab or by the cast. So there is a risk of compartment syndrome. Now we will discuss compartment syndrome. So there is an increased pressure in the compartments of the, because tibia lower limb is divided into the different compartments. Now we can see from this picture, the lower leg can be divided into the 4 compartments: anterior compartment, lateral compartment, and the deep compartment, and superficial compartment of the posterior side. So the all blood vessels and the nerves passing through these compartments. So injury to these vessels can lead to the compartment syndrome. So for compartment syndrome, we should remember the 5 P's. Patient will complain pain. Clinically, there will be a pallor, pulselessness, paresthesia, and paralysis. Yani we should remember 5 P's. If there is pain, pallor, pulselessness, paresthesia, and paralysis, so we should suspect compartment syndrome. Compartment syndrome, this is an emergency and need immediate intervention. And most of the time, this is the surgical intervention. So in the picture, we can see this is the fasciotomy to release the pressure of the compartment syndrome. Need to the release pressure from the all 4 compartments. So if there is compartment syndrome, this also we will assess for the neurovascular injury. So there will be the foot drop, there will be a loss of the sensation of the dorsal and the plantar side as a result of the injury to the tibial nerve and the peroneal nerve. Now we'll see the anatomy of the ankle or the distal tibia and fibula. The ankle joint, this is the formation of the joint with the combination of the tibia, fibula, and the talus bone. This is the radiological view of the ankle joint. So in the ankle joint, we should ask about for 3 type of radiological imaging: X-ray, AP view, lateral view, and the mortise view. So mortise view is very important. Mortise view can slightly dorsally flex at about internally rotation for 15 to 20 degree, and it will be clearly, and we can see clearly distal fibula and tibia in this view. because if more view will not be done, we cannot see clearly the distal part of the tibia and can be missed fracture of the posterior malleolus. So these are the fractures in the ankle joint. Fractures can be the of the lateral malleolus, medial malleolus, or can be the posterior malleolus, or can be with the combination of all these malleolus. These fractures mostly due to the also high energy trauma or fall down from the height or the force, rotationary force because of the sport injuries during football or running can also be happen the fractures of the ankle. So these are also the radiological imaging showing the fractures of the ankle joint. This is a CT scan also showing the fractures of the ankle. So any fracture at the ankle joint also, as ER physician, we should immobilize the patient by applying the splint posterior slab, provide the patient with the proper analgesia. If there is any external bleeding due to the open wound, we should apply compression. We can apply the primary sutures. So simple fractures will be managed conservatively by applying the posterior slab or cast. If fractures are displaced, so it will be managed with open reduction and internal fixation. So in this picture, we can see there is screw fixation of the medial malleolus and the plating of the lateral malleolus. Sometime by applying the in fractures of the ankle, bully formation can happen or blisters can be formed. If blisters can be formed, so cannot be performed open reduction and internal fixation. First should be managed healing of these blisters, and after that should be performed surgery. So all these fractures, if undisplaced, managed with the cast or the posterior slab, and patient will be advised for non-weight bearing. In the ankle joint, sometimes we receive patient in the ER with the deep cut wound on the posterior aspect of the ankle. So whenever we receive the patient with the deep cut wound on the posterior aspect of the foot, we should keep in our mind any injury to the Achilles tendon. Achilles tendon, this is the strong tendon located on the posterior aspect of the ankle, and this is the attachment of the soleus muscle to the calcaneus. So any cut wound located on the posterior aspect of the ankle, we should suspect and we should examine the patient for the injury to the tendon. How we can examine the patient for the Achilles tendon injury? We can ask the patient to sit on the stretcher and we can squeeze the calf muscle. If patient was unable to move his foot or there is no any dorsiflexion of the foot, so there is injury, complete injury to the Achilles tendon. If there is complete injury to the Achilles tendon, this needs surgical repair. So in this picture, we can see there is cut wound on the posterior aspect of the foot. So if there is any positive test for the Achilles tendon, this test is known as Thompson test. By squeezing the calf muscle, and patient will be unable to do the dorsiflexion of the foot. So in this case, we should inform the orthopedic specialist because this patient needs surgical repair. If there is partial injury, this can be repaired by the orthopedic specialist in the ER. If this will be the complete injury to the Achilles tendon, this need repair in the operation theater. But from ER, we need to immobilize the patient. This is in the picture. We can see the cast applied to the patient with the Achilles tendon injury. So we can see the cast applied in the position of the plantar flexion. Otherwise, if there is fracture to the distal tibia, we applying the cast and keeping the angle at 90 degree. So in ankle joint, there will be also fractures, there will be a dislocation. As other dislocation, ankle dislocation is also an acute emergency because it can lead to the risk of neurovascular injury. So clinically, this patient will also be present with the same severe pain, obvious deformity, inability to bear weight and walk, intense pain. So clinically, there will be the bruising, ecchymosis. So we should assess for the neurovascular injury also. We should palpate for the dorsalis pedis pulse, capillary refill, lateral malleolus and medial malleolus pulses. So if there is any deficiency in these pulses, so this may be the injury to the vascular injury. So dislocation of the ankle can be anterior, posterior, lateral, or the medial, depending upon the force of applying on the patient. Posterior displacement, it will the backward movement, and this is the most common type of the ankle dislocation. So for diagnosis also same, we need to do the X-ray to confirm the position of the bones. We need to do AP and lateral view. If there is combination of the dislocation with the fracture, so we need to do CT scan to completely assess the joint. Like all of the dislocation, ankle dislocation also need urgent reduction. So we should involve the orthopedic specialist immediately. So this can be a trial of closed reduction. If closed reduction fail, so this can lead to the open reduction. So from ER, we can apply the posterior flap to immobilize the limb. So in these pictures, we can see the deformity. In case of ankle dislocation, there is clear deformity, ecchymosis. There is also some pictures showing the fracture of the distal tibia and fibula, displays fractures with dislocation. So now we will see the calcaneus fractures. So calcaneus located below the talus bone and making joints with the talus bones. To describe the calcaneus bone, there is one thing very important. We will discuss this one, known as the Bohler angle. This is the radiological assessment of the calcaneal fracture. Bohler angle has two lines. One line starting from the superior tuberosity of the calcaneus and passing through the posterior articular facet. Second line starting from the anterior process of the calcaneus and passing through the posterior articular facet. So this angle normally between the 20 to 40 degree. If there is any decrease in the angle, it can describe the intensity or the severity of the calcaneal fractures. Calcaneal fractures mostly happens due to the fall down from the height. These can be a simple fractures and displaced fractures or the comminuted fractures. So here we can see the X-rays and CT scan showing the fractures of the calcaneus, displaced fractures. This is also the CT scan and the X-rays showing the fracture of the calcaneus. Some X-rays showing the open reduction and internal fixation with the screws or with the plates. So lastly, we see there is foot, anatomy of the foot. Foot is divided into that talus bones, tarsal bone, metatarsal bone, and phalanges. Tarsal bones are the navicular bone and three types of the cuneiform bones, and the five metatarsal bones and the phalangeal bones. So these are the pictures showing the displays and comminuted fracture of the metatarsal bones. Also showing the displaced fractures of the tarsal and metatarsal bones and their internal fixation. So this picture showing the dislocation of the tarsal metatarsal joints. So like all other dislocation in the foot also need urgent reduction. Like other dislocation, this is also an emergency, so need urgent reduction. So in the foot, in ER, mostly we receive dislocation in the interphalangeal joints, which can be reduced by ER residents, or if not reduced, we should involve the orthopedic specialists. So all type of the fractures in the lower limb can be open fractures or closed fractures. So in ER, if we see there is open fracture, we should irrigate the wound properly. We should do the pain management. We should start IV antibiotics because there is a risk of infection. If the need, we can apply the primary sutures to stop the bleeding. And we can apply the posterior slabs or cast according to the situation. The most important things, red flags in the lower limb. Once again, we will discuss this one. If there is any neurovascular injury, we should not delay the management. We should immediately involve the orthopedic specialist or team leader. If there is open fracture, should not delay the management. Immediately involve the team leader or orthopedic specialist, because these are the red flags. If there is any delay, this can lead to the severe complications, or this can lead to the any invalidity to the patient and can be the lifetime complications. So as ER physicians, we should properly diagnose these types of the fracture, early diagnosis, early management for the open fractures or displaced fractures. Simple fractures can be discharged from the ER with the cast or with the posterior slabs. Okay, this is finished. Thanks for all of you for listening this lecture. So if there is any question, any suggestion, or anyone want to add something to this lecture?
Thank you, Dr. Amran, for this comprehensive, great lecture. Actually, Dr. Amran did a great effort. He is post-night shift, and he insisted to give a lecture on time. Thanks to Dr. Amran. Thanks, Dr. Khalid, for his supervision and follow-up. If anyone wanted to ask any question from Dr. Amran, Dr. Khalid, if you want to add anything.
Thank you very much, Dr. Amran, for a very good and very informative lecture. Appreciating you very much regarding this effort.
Thank you, Dr. Khalid. Thank you, Dr. Haytham. This is all about of your efforts also.
Thank you. Actually, this lecture is also recorded and we will upload for our colleagues if they want to revise or check any point at any time so they can enjoy this exciting lecture. Thank you very much and see you soon, inshallah. Thank you.
Inshallah. Thanks all of you.
Thank you.